very much for having me here, to Dr. Belardi and the organizing committee for inviting me. It's an honor to be here, and thank you all for your patience in listening to me present in English because my Spanish is so poor. Thank you very much for the chance to talk about digital health and the future of cardiology. I think it's important when we talk about digital technologies to pause and understand the important advances we have made in cardiovascular science and cardiovascular medicine. We have made remarkable advances that have improved the care and outcomes of patients. Perhaps the best example is acute myocardial infarction, where a combination of surgical advances, interventional advances, and pharmaceutical advances have significantly improved outcomes compared to just a couple of decades ago. And we should also acknowledge that cardiology is a very high technology field. When new technologies come in, for example, in the cath lab or the EP lab, we adopt them very quickly. So we have no fear of technology, and we have a lot of cardiovascular science and medicine behind us. So then what's the problem? The problem is that all those advances in science and medicine are not getting to our patients consistently. We have a problem with the way we deliver healthcare, the healthcare delivery system, because despite all these exciting advances, we know that heart disease remains the leading cause of mortality and morbidity and is a leading cause of costs in healthcare, certainly in the United States, but also globally. And we also know that heart disease is actually increasing in most countries. And this is not just a problem in the United States, it's a global problem where we are seeing an epidemic of an increase in cardiovascular risk factors, hypertension, obesity, diabetes, tobacco use around the globe, and it's epidemic in places like China and other countries, India, and so forth. This is a serious challenge to us to improve the care and outcomes of our patients. So what is the problem with the healthcare delivery system? It boils down to one word: variation. We have unexplained variation in the way, or consistency, in the way with which we deliver care and the quality of our care, in our risk factor management and identification and optimizing risk factors. And yes, we have high variation in health and health outcomes inside every single country in which it's been looked at. And even when there are attempts to look at it, even when there are attempts to look at overall health and quality and access to care, we see high variation across the world. And yes, the United States and Argentina, neither country is in the top. We are in the middle together with how well we do this because of variation in the way we deliver the care. This is why many people have said what we need is digital disruption or digital transformation in healthcare in the way we deliver the healthcare. Why now? Well, let's go back 60 years. 60 years ago, this is what it took to load a 5 megabyte hard drive for IBM just 60 years ago. Now in my hands, I have a smartphone that's 256 gigabytes. So the exponential growth in computing power, the exponential growth in digital data, and the way to move digital data across the internet have led to the digital transformation of most sectors of the economy. So outside of healthcare, we've already seen this. We see much more efficiency. We see better customer service, and we see better outcomes, or of the products, or of what we want to do, we do it better. This is the so-called promise of digital transformation. And most people point to the cell phone or the smartphone as the most obvious example of successful digital transformation. If it's done right, it should make us better at what we do and improve our efficiency and take over tasks that we don't need to do anymore. And that's if it's done right. So what about healthcare? How are we doing in delivering healthcare? Let's go back again 60 years, the same 60 years. 60 years ago, this is how we delivered healthcare in a hospital waiting room. And if you fast forward to today, it's not changed. It still looks like we're delivering healthcare the way we deliver the motor vehicles or another government office. We have not fundamentally changed the way we're delivering care to use digital tools. However, if you go to Silicon Valley or to the technology companies, they think that we have changed already. They have been telling us for years that a digital revolution in healthcare is speeding up, and that data analytics, remote care, and interconnectivity are prepared to transform medical care. The problem with these headlines is that they've been the same headlines every year since 2010, then 2011, 2012, et cetera. We keep hearing that a digital revolution is coming, but it hasn't happened. Now, it's important to say this has not slowed down investment in digital health. In the United States alone, just in startup companies, over $8 billion were invested last year and the year before. It's a crazy amount of money going into the digital health world by the technology companies. Well, wait a second, where has all that money gone? I mean, what has all that money led to so far? If they've been investing all these years, what has happened in digital health? Well, the main thing that has happened is this. Hundreds and hundreds and hundreds of digital health startup companies exist. And this doesn't even count the big ones, Google and Apple, okay, Facebook. But we have so many startup companies, this has been referred to as a kaleidoscope of technology. And you can't even keep up with this because the companies come and go. So it's overwhelming how many digital health companies there are out there in digital technologies. We need a way to know which ones or which technologies to adopt and when. Now, how can there be that much money and that much technology, and yet when you go to my hospital and my clinic room, it still looks the same way it did the day I got there in 1994 as a cardiology fellow? It's not digital, except for I do have a computer for the electronic health record. Even the clock in the room is not digital. And I'm not using digital tools to take care of my patients outside the walls of the hospital or outside the walls of the clinic yet, even though there's all those digital health companies and all those apps out there. So we have a major gap between the technology world and the clinical world. And I believe that we need to close that gap. But why is there a gap? How is that even possible that there's a gap? Well, the first problem is evidence. Until now, or at least up to this point, the hype around digital health and artificial intelligence is way ahead of the actual evidence. And I think we need to acknowledge that. Just because it's exciting technology does not mean it's ready to deploy in the care of our patients unless we know it's going to make us more efficient and improve health and health outcomes. I do believe this will improve. I absolutely believe we will build this evidence base. But I think we have to know that a lot of the studies of digital health interventions that have been published in the literature have not been positive. They've been neutral or negative studies, including, for example, the Scripps Wired for Health study by Dr. Eric Topol. Many people thought this would show that if we deploy digital tools at the homes of our patients, we would improve care, save money, and improve outcomes. And it did not show that. So we have work to do to build the evidence base for digital health. We have other issues here that we have to overcome. We should accept these as challenges. One of these is this, that a lot of the startup companies are making technology solutions that are in search of a problem. That is, they aren't necessarily solving the clinical problems that we need or that our patients or their families need. They're very fancy. They can have amazing looking technology. That doesn't mean it's going to work when we take care of patients. The second problem we see all the time from Silicon Valley and the startup companies is this idea that they think we want data all the time. They think we want a sensor on the arms of our patients that will give us 24-hour a day, 7-day a week, 365-day a year physiologic information or data just streamed to us. What are we going to do with that data? Data alone is not enough. What we need is information out of that data that gives us information we haven't had before to take care of our patients. One thing that is absolutely true is that in most, not all, but in most technology companies, they really don't understand clinical medicine or clinical care or the way we work with our patients and our families. So they have not designed the technology to help us get better. And last but not least, we have issues around payment. Now, in the United States, this is particularly true, where in our current major fee-for-service system, we don't necessarily have a way to get paid, even if we want to use these digital tools. And then there's the question of cost effectiveness, which is not proven. We also have one more challenge in the United States and globally, but maybe better here locally, in Argentina, which is our electronic health records were designed for insurance billing. They require onerous documentation by the doctors and nurses, and they do not deliver on the promise of digital transformation. They're not making us more efficient, they're making us less efficient. So this is now making us less interested in adopting digital tools, because so far the digital tool we have has been very difficult. And there are studies, as you probably know, showing that physicians, at least in the United States, are spending 2, 3, or 4 times as much time documenting the electronic health record than they are taking care of their patients. So I think we should summarize that as of today, the future may be digital health, but the future is not here, at least yet. Now, do I believe it will get here? I absolutely do, of course. But I think we need a roadmap. We need a way to have this happen. It's not going to be the same as the non-healthcare sector, because outside of healthcare, when you're deciding what movie you want to watch or what product you want to buy on Amazon, it is not the same as making decisions about health and healthcare for our patients. So, let me shift to what we're trying to do with the American College of Cardiology. We are certainly trying to do nothing by ourselves. We need help, we need collaboration, and we need people who are enthusiastic about building the evidence and integrating digital health into care. We have started working with patient groups, with payers, governments, innovation centers, and technology companies directly for the first time to try to lay out a roadmap for innovation, which we published at the end of 2017 as a health policy statement. And we did get a lot of positive attention from the technology world. Ever since we published this, we have lots of outreach from companies, the big companies and the startup companies, saying, are you serious about working with us on digital health? And we are. I won't spend much time on this, but I just want to emphasize that we understand there are a lot of steps to digital transformation. We have to know what problem we're trying to solve, what are the priorities. We have to think about workflow integration. How will digital health data, even from a watch, Apple Watch, how is that going to come into care so that it's not just more work on our day and we can make informed decisions based on the new information? Who are we going to partner with? Because we can't do this alone, and I think we have to partner directly with the tech companies, which I'll show you again in a second. And we have to evaluate what we're doing. We can't just assume it's going to work and save money and make us more efficient. We're going to have to evaluate it in real clinical settings. Let's get down to what we're looking at. When we're saying digital health transformation and the ACC is going to work with tech companies, what are we working with them to do? There are 4 buckets here, 4 areas. The first is what I would call digital tools. Digital tools are used to improve what we do already today inside hospitals or clinics to make us more efficient, more accurate, and bring new information. So just 2 quick examples. One would be handheld or point-of-care ultrasound or echo. The technology is advancing so rapidly, some of you will know this specific brand here called Butterfly. It has artificial intelligence in the probe, in a single probe. It actually guides you to the optimal view. And so I think the point-of-care ultrasound will shift how quickly and rapidly we can diagnose. The second one here I just wanted to show, which is doing an Allen's test, but instead of doing it manually as a physician or a clinician, using a smartphone camera. And it was a small randomized trial that showed that the app was superior to clinicians in conducting an Allen's test. So these are the kinds of things we can and should adopt sooner rather than later. The second area is virtual care, so telehealth or telemedicine. I think this has become mature now, and we are quickly adopting virtual visits and virtual care, and even the payment models in the United States are catching up to incentivize the use of these in addition to. Now, does this replace what we do in the hospital? It doesn't replace when somebody needs to be in the hospital, but what about in follow-up from the hospital, or when we're treating conditions like hypertension or heart failure and we just need to have follow-up visits to titrate medications? It is crazy to have people drive, especially long distances, back into the hospital when we should be using more virtual care. But I think the real frontiers are the following two. I think these two are lower bars. The harder ones, the more difficult ones, the more exciting ones are remote monitoring and artificial intelligence guided care. So let's start with remote monitoring. This is the promise of utilizing data we did not have before to inform prevention, care management, and health promotion. What's this going to come from? This is going to come, yes, from mobile apps, but also wearable and non-wearable biosensors and voice recognition technologies. Those are just to name a few. And these are moving very fast. I have seen just in the last 2 years advances in the sensors that are moving so fast that it's actually a little hard to keep up, but we need to evaluate them in clinical settings. I think we're all aware of the Apple Watch and things like it, which give us very high fidelity signals. Now we need to figure out how we get them into care. And we're seeing better digital platforms and non-wearable sensors like from sleep. We're seeing some very interesting physiology in heart failure patients, for example, which predicts decompensation way earlier before they have symptoms or even gain weight. And as far as AI-driven care, AI tends to be an overused term, but I think we can think about it as analytics that improve prediction, interpretation, especially of images, and digital therapeutics, which including direct to consumers someday, with the care team acting on it to guide care. AI care is early, but the places where it's going to succeed first are going to be in imaging. This is happening very quickly. We are already seeing in radiology, for example, that AI interpretation of chest X-ray, CAT scan, MRI is as good or better than radiologists and expert clinicians. And we're seeing some really interesting things in the images. It's not just interpreting it. The AI can also predict risk based on the images. So with retinograms, we can see on retinal scans, not just the diagnosis, and the AI is better than the radiologist or ophthalmologist, but it can actually predict who's going to go on to develop heart disease. And in this, on the right, Google worked with Stanford on pathology specimens of cancer, and not only could the AI read and interpret the pathology of which cancer it was, but it actually could, based on the pattern, identify the underlying genetic defect related to the cancer, which can guide which chemotherapy would be most effective for the patient. So what about us? What about in cardiology? Well, a year ago I would have stopped, about a year ago I would have stopped at that last slide, but this is now moving very fast. Cardiac CT, cardiac MR, and yes, echocardiography is moving very fast in the AI interpretation world. This was published 1 year ago, and I believe will be looked back upon as a seminal study in AI and cardiology. Fully automated echocardiogram interpretation in clinical practice. This is a preliminary study, but the investigators were able to show 2D echo only, no Doppler, and they were able to show that the AI could quickly learn to discern 11 standard views of echo and then interpret those against known cases. And if you look, they were able to detect hypertrophic cardiomyopathy, cardiac amyloid, and pulmonary hypertension. And remember, this is pulmonary hypertension without Doppler, with C statistics, or area under the curve, of 0.93, 0.87, and 0.85. For a preliminary study, this is very important, and my prediction will be that within 3 to 5 years, we will have AI at least doing pre-reading of all of our ECGs, echoes, cardiac CTs, and MRs. Now, risk prediction is going to take longer because the underlying data in the electronic health record is variable and not very good, especially in the United States. So while everybody wants to do AI to do risk prediction or these things, I think this will be slower than imaging. However, we are seeing some lights. We are seeing some impressive publications starting to come out, even if they're limited to 1 or 2 places. And this is the best example of that. This is a study that was done by Google, but they did it in collaboration with clinicians at UCSF, Stanford, and the University of Chicago. And they had 2 hospitals that used the same electronic health record, so they had consistency of data. And at least in that setting, they were able to use artificial intelligence against the massive amount of data in the EHR. And when I say massive data, I mean massive data. When I read the abstract for this publication, I thought, wow, that's amazing. They had 46 million data points. And then I realized I missed a comma. It's 46 billion data elements. This is the power of artificial intelligence that normal biostatistics cannot handle. And look at the prediction here, the area under the curve, or C-index, in-hospital mortality, 0.93, prolonged length of stay, 0.85, et cetera. Now, is this ready for us to use in clinics? Should we run out and use this today, tomorrow, in our hospitals and clinics? No, because it would have to be validated, just like any risk score, in other settings. And we still don't quite know how to bring it into how we make care decisions. But at least it's evidence, and at least it's published, and I think it shows us the hope down the line that this will become something we do. For the American College of Cardiology, and then I'll wrap up, we are trying to position ourselves to lead this rather than have it done to us with the technology companies just giving us products. I think we need to lead this from cardiovascular medicine and say, what are the problems we're trying to solve with artificial intelligence and digital health? We have a lot of data from the registries in the United States. We get data from across the United States, digital data, high quality data. And we are working with Yale University and others on applying artificial intelligence to compare whether it is or isn't better than the risk adjustment and risk prediction models we already have. And we have made the leap to starting to work with the tech companies and with innovation centers around the world. So these are our current partners, and I would love to add more to this slide if any of you are interested. On your right are strategic partners for our innovation program, because we can't do this alone. Some of these are in the United States, but increasingly these are global partners, such as BioInnovate Ireland and Israel Innovation Institute. We are thinking the same way about how we're going to evaluate and deploy digital health and AI in clinical care. And on the left is the part that is a little more scary, in that we've decided to work with selected startup companies and actually co-develop the technology from scratch. So we are developing digital tools such as remote monitoring platform for patients with heart failure and digital modules for engagement of patients and monitoring with wearables for atrial fibrillation. And these are the companies we're working with. If any of you have any interest in learning more about them, I'm happy to share what we're trying to do and how we're going to develop and then deploy this in clinical care. Now, earlier in the talk, I showed you a slide with too many companies and a lot of logos, and here I am again showing you a slide with quite a few logos. So I have to end with a promise, which is I promise that as we do this, the ACC and our partners, we will not fall in love with the technology. We will stay focused on what problem we're trying to solve for our patients and their families. And we will always think that the best way to develop and deploy digital technologies is to develop them from the beginning with clinical intelligence and thinking about how we're going to use them in our care to become more virtual, remote monitoring, and AI-driven care. That's fine, but we have to think about how we're going to do that in our daily practice. And I will leave you with two things. One is, I don't believe it's going to be that AI replaces cardiologists. I believe that AI will make us better at what we do. This is a concept called augmented intelligence that was brought out in this excellent editorial by Abraham Verghese, Bob Harrington, and others at Stanford. What this computer needs is a physician, humanism and artificial intelligence, and it's about how we can use AI to add more statistical automation to what we do, and yes, get better, and yes, get more time with our patients and be more humanistic in what we do. Ultimately, I believe that in the future, and I believe this future is only 3 to 5 years away, digital health and digital medicine will just be called health and medicine. Thank you very much for your time.